History. My patient, Asmita, 36-year-old female, resident of Delhi, factory worker by occupation, came to OPD with chief complaints of ulceroproliferative growth in the left side of oral cavity since 8 months. Patient was apparently all right 8 months back when, while brushing her teeth, she noticed bleeding from the oral cavity and found an ulcer near her left lower tooth. Initially, it was small in size, approximately 0.5 by 0.5 centimeter, insidious in onset, and gradually progressed to its current size. The lesion patient experiences pain on touch. It is relieved temporarily on medications and aggravated on eating spicy food. She also complains of bleeding on trivial trauma, but stops spontaneously. She consulted a local practitioner who advised her oral medications and mouthwash. The ulcer did not resolve, hence she consulted the ENT department of a tertiary care hospital in March 2022. An edge biopsy was sent under local anesthesia. Patient was diagnosed with malignancy of the oral cavity and referred to Department of Plastic Surgery for coverage post-excision. Negative history. There is no history of sharp tooth or ill-fitting dentures, loosening of teeth, loss of dentition, dental pain or earache, high-risk behavior, difficulty in chewing or trismus, difficulty in swallowing, drooling of saliva, change in voice or hoarseness, cough, hemoptysis, loss of appetite, loss of weight, or any neck swellings. Past history. History of LSCS 14 years back. She is not a known case of diabetes, tuberculosis, hypertension, ischemic heart disease, or bronchial asthma. There is no history of any other surgery in the past. Personal history. History of tobacco consumption in the form of gutka chewing for 3 to 4 years, which she stopped 10 years back. She used to keep a tobacco quid in the lower gingivobuccal sulcus and sleep with it. Sometimes she used to chew it and throw it. Sometimes she used to chew and swallow it. Sleep is adequate. Appetite is normal. Bladder bowel habitus are normal. No history of any alcohol consumption. No history of any high-risk behavior. Family history is not significant. Menstrual history. Her last menstrual period was on 6th of June 2022. It is regular every 24 to 28 days. And she is P2, L2, A0 and LSCS was done 14 years back. Can I continue to the general physical examination?
Yeah, you can continue. I'll like to, since you're preparing for exams, this is in. So when you are starting with your presentation, don't give the diagnosis. You said, no, I'm presenting a case of CA oral cavity. And second is not to mention the heading negative history. That was in history part, these 2 points. If anything else, anybody wants to add, Dr. Vijay, anything you want to add? So you can continue.
General physical examination. Patient was examined in a well-lit room after verbal consent. Patient is conscious, cooperative, well-oriented in time, place, and person, moderately built and averagely nourished. Pulse is 90 beats per minute in right radial artery. Blood pressure was 130 by 90 millimeters of mercury, left arm supine position. Respiratory rate was 16 per minute. Her weight is 50 kg and height is 1.5 meters. So BMI is 22 kg per meter square. Her ECOG performance status is 0. There is no pallor, icterus, clubbing, cyanosis, generalized lymphadenopathy or edema. Pedal edema. Systemic examination. CVS S1, S2 was heard, no murmur. RS bilateral air entry was equal. Per abdomen was soft, no organomegaly. CNS, she was conscious oriented. Local examination of the head and neck. On inspection, facial symmetry is intact. There is no visible fullness or neck swelling. Mouth opening is 3 fingers. Oral dental hygiene was poor. There was halitosis, nicotine staining of the teeth, and dental caries. Tongue protrusion is normal. There were no leukoplakic or erythroplakic patches. A single ulceroproliferative lesion of size approximately 1.5 by 1 centimeter is visible in the left lower buccal mucosa, extending anterior to posterior from second molar to the third left lower molar. Superior extent is 4 centimeter below the upper gingivobuccal sulcus, and inferior extent is.
Presentation is gone.
We have lost your screen.
Now is it visible?
No.
Close and share once again.
Yes, sir. So now is it visible?
Yeah.
Yes. A single ulceroproliferative lesion of size approximately 1.5 by 1 centimeter is visible in the left lower buccal mucosa, extending anterior to posterior from second molar to the third left lower molar. Superior extent is 4 centimeter below the upper gingivobuccal sulcus and inferior extent is up to the lower gingivobuccal sulcus. It is ill-defined, having irregular margins, everted edges. Floor is covered with slab. The floor of the mouth, tongue, upper gingivobuccal sulcus, upper alveolus, and retromolar trigone appear free. The dental formula of the patient is 2123, total 32 teeth, and occlusion is angle class 1. On palpation, the findings of inspection were confirmed. A single tender ulceroproliferative lesion of size 1.5 cm in length and 1 cm height is seen in the left lower buccal mucosa, extending anterior to posterior from the second left lower molar to the third molar, which bleeds on touch. Consistency is hard. It is mobile. A 0.5 millimeters of induration is palpable all around the lesion. The mandible appears free. Overlying skin is pinchable. There is no loss of sensation over the lower lip. TMJ examination was normal and examination of the scalp was normal. Neck examination, there was no palpable cervical lymphadenopathy. My diagnosis, sir, can I go to the diagnosis?
A few things I would like to highlight. Could you go to the photographs?
Yes.
Yeah. So you said there is no erythroplakia or leukoplakia. I agree on leukoplakia part of it, but what about this stained part of the tongue and the cheek on both the sides? What would you call that?
Some melanoplakia.
Melanoplakia. So all the positive findings have to be told.
Yes, sir.
Okay. And second point is you said the mandible appears free.
Yes.
So I agree to that, but I think it is much better in case you say mention about the gingivobuccal sulcus. Okay. So what about the lesion is stopping short of the gingiva, yes, is only into the buccal? That will give the examiner that you have really objectively analyzed the patient. Okay. Otherwise, so these are 2-3 points I could see. In case ma'am wants to add anything to this.
Ankita, I would like to ask you one point finding.
Yes,
additional to the inspectory findings, what are the important palpatory findings you told?
Ma'am, in palpation, ma'am, regarding the apart from inspectory finding, I examined regarding the consistency, the mobility, the pinchability of the overlying skin, movements of the involvement of the mandible, the TMJ movements, and palpation of the cervical lymph nodes, ma'am.
Have you told in specific induration around the ulcer?
Yes, ma'am. 0.5 millimeters of induration is present around the ulcer, ma'am.
All around the ulcer?
Yes, ma'am. Yes, ma'am.
You mentioned that? Okay.
0.5 millimeter. Yes, ma'am.
Okay. Okay. Right. Okay, then you go ahead.
Yeah. This photograph. Sorry.
Yes,
what is whitish patch which is visible on the right side?
Sir, that is the reflection of the camera, the flash.
Show us one second. No, on the right side of the patient. The previous picture.
Not left side, right side.
So this one?
Yeah. In between the teeth, there is whitish patch which is visible. Just behind melanoplakia, there is
it's a submucous fibrosis.
Yeah, it looks like that. Whether you have palpated that. So
yes, sir, I palpated, but I could not appreciate any firmness or induration in that.
Again, whenever you see abnormal color, just mention it.
Yes, sir. Yes, sir.
Okay, that's fine.
Yes, sir.
Carry on, please.
Yes.
The diagnosis. My diagnosis is an ulcer-proliferative lesion of the left lower buccal mucosa without cervical lymphadenopathy of 8 months duration in a biopsy-proven case of carcinoma left buccal mucosa in a 36-year-old tobacco chewer female. So TNM staging is C T2N0MX stage 2 according to AJCC 8th edition. Hello.
Yeah, that's fine. That's fine. So in exam, I think biopsy will be made available to you. Do you have these findings available to you now? What type
Yes, sir. Yeah. Yes, sir. It is well differentiated squamous cell carcinoma.
So what does that mean? Well differentiated?
Sir, histologically, we can the histological classification of squamous cell carcinoma. On the basis of that, we can classify it depending on the amount of keratin pearls which are present, invasion, lymphovascular invasion which is present into well differentiated, moderately differentiated, or poorly differentiated squamous cell carcinoma.
So what is the relevance?
Sir, depending upon the whether it is well differentiated, moderately differentiated, or poorly differentiated, the further plan of management will depend upon the extent of excision and the post-operative chemotherapy and radiotherapy protocol which will be given to the patient. If it is poorly differentiated, then we will have to go for radiotherapy in the post-operative period, sir.
No, is it?
Yes, sir. Indication for radiotherapy, one of the indications is poorly differentiated on biopsy.
Yeah, okay, agreed. So what is your plan?
That is agreed. It poorly differentiated ulcers will be more sensitive to radiotherapy. But depending upon the histological status, diagnosis, and the well differentiated, poorly differentiated, the margin will not change.
Yes, ma'am.
Okay.
Yes, ma'am.
And I want to add, will your management change this time if it is moderately differentiated, not well, or it is poorly differentiated? Your management plan will change at this stage?
Sir, if it is poorly differentiated, I would like to take a margin. In my institution, there is availability of frozen section. So I have taken 1 centimeter margin, but if it was not available and it was poorly differentiated, I would go for a 2 centimeter margin for excision of the lesion.
Why? The frozen section is actually everywhere available nowadays. But why will you go for 2 centimeter and if it is 1 centimeter? Is it documented
Is it
somewhere?
followed by your oncologist?
No, ma'am. In our institution, we take 1 centimeter only, ma'am.
Yeah.
That is why
Usually it will not
mentioned somewhere that
change
you
the
take
modality.
2. It is not like
Especially
that.
in stage 2, it is always surgical. With stage 3 or 4, if you want to give neoadjuvant and download the staging and go for surgery, maybe the radiotherapy is different, but not in stage 2, which is amenable for the surgical resection, isn't it?
Yes, ma'am.
The margin also only 1 centimeter is always given by everybody. Depending upon the histological status of biopsy, nobody changes the margin.
Okay.
Maybe for melanoma, you may say
Yeah.
depends on the depth and all that. And for frozen section is always available. I think it must be available with you people also.
Yes, sir. Yes, sir.
Then better is to take a frozen section than to say like we can see you go for 1, 2, 3. It is not like that. And I have not come across, maybe you have come across somewhere that if it is poorly differentiated, we can go for 2 centimeter. If it is well differentiated, we can go for 1 centimeter.
Okay, sir.
Right?
Yeah, Dr. Ankita, the bottom line is that the stage will decide the excision. So whether it is well differentiated, poorly differentiated, that will affect the prognosis and recurrence.
Yes.
That is what we need to understand. So margins will not change and modality also will not change. You said that in case it is poorly differentiated, I'll use radiotherapy. It is not written like that. What is mentioned is poorly differentiated might respond to radiotherapy. It doesn't say that you have to give a multimodality treatment. So the straight answer to simple answer to the question is, what is the relevance of poorly differentiated, well differentiated? A young patient developing a poorly differentiated malignancy, prognosis is poor and chances of recurrent disease are higher. So that should be the answer. It should not affect any margins or the morality. Yeah.
One thing, a margin it will not affect, but if the patient is emaciated and not fit for surgery and poorly differentiated, pre-op radiotherapy can be sent, isn't it, sir?
Yeah. It can be sent, but again, the final excision will depend on the pre-RT margins.
Yes.
Exactly.
Yes. So there should be a little clarity in this. So
Yes.
Ankita, I think it is clear now.
Yes, ma'am. Yes, ma'am.
Go ahead.
Ma'am, defect size calculation I have done. My lesion is 1.5 by 1 centimeter. There is induration of 0.5 millimeter all around. So actual lesion is 2.5 by 2 centimeter. And considering 1 centimeter margin for wide local excision, my total defect size has come out to be 4.5 by 4 centimeter.
Okay.
2.5 or 4.5?
And 4.5.
Okay, 2.5. Okay, 2 right.
Agreed. Go ahead.
Defect size is 4.5 into 4. Right.
Yes. Ma'am, my plan of management, so should I directly go to plan of management or should I go to the investigations?
Without going, mentioning the investigations, how will you go?
Yes, ma'am.
Isn't it?
Yes, ma'am. Yes, ma'am.
Actually, management has two parts: investigations and
First,
treatment.
even the staging also, you will diagnose clinically and do the investigations. Then only you will tell that final
Yes,
stage.
yes, ma'am.
Yes.
For the management of the patient, I would like to do investigations to confirm the diagnosis, to stage the disease and treat the patient. For confirmation of the diagnosis, already a edge biopsy of the patient has been sent. In addition to that, for examination of the neck nodes, a CECT of the head and neck, contrast enhanced CT scan of the head and neck region is required. Basic investigation, blood investigations for anesthetic fitness, and ideal can be done on OPD basis. And USG of the abdomen if any suspicion of organomegaly is if any suspicion of distant metastasis is present.
Even there is no suspicion also, you have to do it.
Okay, ma'am.
Okay.
Yes, ma'am.
So, Dr. Ankita, what is field cancerization?
Sir, field cancerization is a concept which has been found in the tumors of the upper aerodigestive tract. According to the concept of field cancerization, due to exposure, continuous exposure of the oral mucosa to the carcinogenic stimulus, which is the nitrosamines, due to the action of the oral bacteria on the nicotine, which is present in the tobacco, there is formation or there are formation of multiple primary tumors within the oral cavity, which are known as spontaneous primary tumors, which occurs within 6 months of the initial occurrence of the first tumor. So, due to the concept of field cancerization, multiple tumors can be present within the.
Agreed. Agreed.
So where else will be there, and how will you diagnose?
Ma'am, due to the field cancerization, I would like to get the patient first examination of the oral cavity and the hidden spots. In examination of the oral cavity in the gingivobuccal sulcus, the
What
tonsillar
investigations you do?
Ma'am, on OPD basis, we can do indirect laryngoscopy, and followed by that, we can also go for pan endoscopy of the patient, triple endoscopy of the patient.
Yes, that is the answer. Already you examined the other parts of the oral cavity, so you have to do triple endoscopy to find the synchronous lesions or field cancerization. Okay.
Yes, ma'am.
What are triple endoscopy?
Ma'am, in triple endoscopy, first we would like it includes examination of the upper aerodigestive tract, which includes endoscopy, bronchoscopy, and tracheobronchoscopy and esophagoscopy.
Okay, go ahead. Other investigations.
Ma'am, CECT of the head and neck for examination of the neck node status. And
what other findings the CECT will give? Only neck node status or anything?
Ma'am, mandible involvement will also be can be ascertained on the CCT of head and neck.
Yes.
So what is the relevance of CCT in diagnosing neck nodes?
Sir, CECT, if there is extranodal extension which is found in CECT,
No, let's talk. What is the relevance? As per your examination, you didn't find any notes.
no, sir.
So how would CECT give you a better information? Extranodal is fine.
Yes, sir. Extranodal extension, if it is present, can be
No,
diagnosed.
extranodal, for that, the node has to be palpable. No? Less
Yes,
than
sir.
2 centimeter node will not through extranodal extension.
Yes, sir.
So what is the relevance of CECT, especially in case of oral cavity when there is no palpable lymph node?
So status of the mandible,
One
involvement of the mandible.
and what is sub-centimetric lymph nodes?
So less than 1 centimeter. If the lymph node enlargement is less than 1 centimeter, which are not clinically palpable.
So that is the
Those are
relevance. That can be
yes.
diagnosed easily. At least
From-
you can come to know that there is some inflammation, and at the time of the surgery you can do some sampling of those nodes.
Yes, sir.
So biopsy is confirmed. You have done triple endoscopy, and there is no synchronous lesion. So
Yes.
GA patient is fit. So you
Yes,
take
sir.
the patient for surgery. So should I read
Yes,
this plan? WLE wide local excision 1 centimeter agreed with marginal mandibulectomy. Why would you do marginal mandibulectomy in this case?
Sir, since the lesion is very close to the mandible, and I want to get a three-dimensional clearance of the same. So I would like to get a marginal mandibulectomy done for this patient. But ideally, if we have to give dental rehabilitation in the same sitting, then I would go for a segmental mandibulectomy.
Come again.
Sir,
So
for
in exam only answer the questions which are being asked. So we know we didn't talk about segmental mandibulectomy. So the question
yes.
is, why would you do a marginal mandibulectomy? You are fine with that because tumor appears to be within 1 centimeter of the margin of the mandible. Chances are to have 1 centimeter margin, you will end up excising a part of mandible. That agreed. Okay.
Yes.
So then you get into another trouble that you want to do dental rehabilitation. Why would you do a dental rehabilitation in a patient with marginal mandibulectomy? Would you really do it? So
Sir,
only answer what is being asked. No, just relax. You know that is we are practicing for exam. Okay, no issues.
yes, sir.
Yeah, it's okay.
Yes, sir.
So otherwise, what is the indication of marginal mandibulectomy? Had this tumor been a bit away and 1 centimeter margin did not extend onto the mandible, would you then also do marginal mandibulectomy or not?
Sir, if mandible is free, then I would not do.
Mandible is free is like long shot. If periosteum is free, then you will not do. If periosteum, there is no plane between the lesion and the periosteum, you will do marginal mandibulectomy. Okay, that is the short answer to that.
Okay, sir.
Okay. Second is supraomoid neck dissection. Why is that?
Sir, since she is a stage 2 patient and there are and lesion is posteriorly located, so there are chances. The most common site of metastasis in oral cavity is to the neck nodes. So I would like to go for a supraomoid neck dissection.
So in simple words, what is the indication of supraomoid neck dissection? 1, 2.
For lymph nodal, sir, nodal involvement, to check for nodal involvement of the patient.
Yeah, staging and sampling both, है ना?
Yes.
Then you will have the complete stage of the tumor. Fine. डॉक्टर उमर, डॉक्टर लक्ष्मी, कोई और पेंडिंग रह गया इसमें अब तक टिल नाउ?
Not much.
Not.
Yeah.
What is the stage of this tumor? How would you stage?
So stage 2, sir.
Means what? T1, T, what is T? What is N? What is M?
So she is T2 N0MX.
N0.
Yes, sir.
There are no nodes palpable?
No, sir.
No node surgery. Then why will you do supraomohyoid?
So, as sir said, for staging and for staging of the patient, nodal involvement we have to do for to check for the nodal involvement.
Any other indication?
For supraomohyoid in this patient.
If it was stage 1, is there any indication for doing supraomohyoid?
Yes, sir. In
What?
stage 1 also, I would do a supraomohyoid neck dissection.
Why?
Sir, most if there are micromets which are present to the neck nodes, they would also be eliminated with the supraomohyoid neck dissection.
Why not selective neck dissection?
So there different types of selective neck dissection is a broad term which includes in which we remove a selective group of lymph node at the risk of micrometastasis in neck node in the neck. It is selective neck dissection includes supraomohyoid neck dissection, jugular neck dissection, anterolateral, posterolateral, central. So it is a type of selective supraomohyoid neck dissection is a type of selective neck dissection.
What levels you will remove?
Sir, in supraomohyoid neck dissection, I would remove level 1, 2, and 3.
1, 2, and 3. Okay.
Okay. Go ahead. Yeah.
Go ahead, Ankita.
Yes, ma'am. My plan of management in this patient would be wide local excision with a 1 centimeter margin with marginal mandibulectomy with ipsilateral supraomohyoid neck dissection and followed by coverage of the defect. My reconstructive options for the same are free radial artery forearm flap would be my first option in the patient, and anastomotic in the neck, sir.
So why not free ALT? Why it is the first option?
Sir, free radial artery forearm flap is my first option in this patient because sir is first is the free radial artery forearm flap. The bulk of the I only need to provide the inner lining to this patient since skin is not involved. So to give a thin and a pliable flap which would not be more bulky, I would prefer a free radial artery over a free ALT. Sir.
Yeah, rightly said. ALT in this patient is thick. It appears thick to you. Have you examined?
Yes, sir. I have examined all the donor sites of the patient.
My only objection is radial artery donor site is a visible donor site.
Yes,
so
sir.
it can have some morbidity, but despite that, you want to go ahead with the radial artery forearm flap because ALT is bulky.
Yes, sir.
Okay.
Ankita,
Yes, ma'am.
your plan of reconstruction is free radial artery forearm flap. So in your examination, have you mentioned anything related to that?
No, ma'am, I have not mentioned regarding the Allen's test and.
Yes, is it not needed?
Yes, ma'am. Yes, ma'am. I have not donor slides, donor sets slides.
So yes, when you examine the donor site, when your flap of choice is a free radial artery forearm, you should tell which side you wanted to take and that is fit for your surgery or not. Okay.
Yes,
So
yes,
you should tell the Allen's test also.
yes, ma'am.
Apart from Allen's test, if you have planned preoperatively about the free radial forearm, what will you advise the patient? Anything you will advise him or her? Now you have planned ALDA free radial forearm. What will you
Yes,
advise?
sir. I would like to know the hand dominance of the patient and what is her occupation, what are her needs, and secondly, sir, I would not allow any cannulation or blood sampling from the same arm. In the
That
preoperation.
also you should tell
That's very
in your
important.
plan.
In general physical examination, that these things are to be told because you know your plan.
Yes,
So
sir.
you have to mention in examination that I will do the Allen's and it will be positive or negative, whatever, right?
Yes.
So we were discussing about free radial artery and you will do it from the non-dominant hand.
Yes.
And the objection which most of us will have is it is a visible site and it can have
Yes.
mobility, especially with regards to tendon exposure. Can
Yes.
you do free radial artery foramen flap and without these complications? Can you modify?
Have you drawn your flap or anything? Are you
Uh,
showing any slides for that?
no, ma'am, I don't have the
Planning
slide.
on the case? No.
No, ma'am, I don't have the slide, ma'am.
So what I was asking was how can you like modify the radial artery foramen flap which will not have all these morbidities? Are you aware? You're not aware.
How will you plan in routine way you tell, and how can you modify to avoid these problems?
Yes, ma'am. In a routine way, ma'am, we first mark the bony prominence, the radial styloid and the cubital fossa crease, and we mark a line joining from the radial styloid to the midpoint of the antecubital fossa, and we palpate the radial artery, and the course of the radial artery is marked. Along with that, if a cephalic vein course is also marked along the course of the artery, and in the distal forearm and with the proximal wrist crease, we will leave around 1 to 2 centimeter, and depending on the defect, ma'am, we will plan the flap including the radial artery and the vein, and at least 2/3 of the at least 2 to 3 centimeter of skin flap should be left on the ulnar border of the while planning.
Okay.
No, you
So
answered the questions are asked. That is routine way. Can you
Yes.
avoid the exposure of these tendons, and there may be loss of skin if you draft it? So in any way you can.
so how would you classify your flap now? So the island is distal and the vessel is proximal. So
Proximal.
what is this
Yes.
flap? I'm putting words into your mouth here.
Distal forearm.
No, distally. Proximally
Distal?
based.
No.
Proximally based.
Your
Radial
Yes.
artery.
vessel is proximal.
Oh, yes, ma'am.
So can you do other way around? Distally based
Yes.
radial artery foramen flap.
Can you plan your paddle on the forearm to avoid this problem?
Yes, ma'am.
So what is that called?
Proximally based. Oh,
No.
sorry, distally based. Sorry, distally based.
Reverse.
Reverse
Reverse.
radial artery.
Reverse radial forearm.
Yes.
Okay. So that can be done. So from exam point, we'll discuss about radial artery foramen flap. Exam point of view, you have to mark the flap, and you should. And I think I don't know why I didn't have the photographs, but anyway, that's fine. So then everything will be clear how you are planning, right?
Yes.
What are the steps you describe? Have you seen the surgery?
Yes, ma'am. Yes, ma'am.
Then you tell.
From marking, ma'am, or from the
Marking you
basic?
already told.
Yes, ma'am.
Proximally based you do, na? So you
Yes.
explain that.
Yes,
And
ma'am.
one
Yes.
more thing you told is cephalic vein, along with the radial artery, it will not be. Okay, you have to mark the cephalic vein and include
ma'am.
in the flap planning. Okay, the
Yes.
course of both will not be same.
Yes,
Okay,
ma'am.
yes,
Yes.
yes. You have to include the cephalic vein, right? You tell the steps now.
Yes, ma'am. Ma'am, once the patient is on table, ma'am, we would first like to raise the flap under tourniquet control, ma'am. So I would like to raise the tourniquet pressure 100 millimeters above the systolic blood pressure of the patient after confirming of the Allen's test and for the patient. After that, uh, we will start the incising after infiltration in the incision in the markings of the flap, ma'am. I would like to start incising the flap, ma'am. Starting, we would like to raise it from distal to proximal approach, ma'am.
Which border you will incise? How will you incise? What is the plane?
Yes, ma'am. Ma'am, it is usually raised in a suprafacial plane, ma'am. In the first, we will if this is proximally based, so we'll start from distal to proximal, ma'am, and till we reach the intermuscular septum, we have to go in the suprafacial plane, ma'am. After that, we will
Which
go beneath the
intramuscular septum? And what structure you will protect?
yes, ma'am.
Which intramuscular septum you are telling?
You are going from ulnar side or radial side?
Sir, from we will start raising it from the radial sides. Sir.
So which intramuscular septum you are preserving? That is the question.
Lateral.
What are the important tendons you will identify? Where the vessel
Brachioradialis
comes?
Brachioradialis and flexor carpi radialis.
Yes.
May I ask another structure you want to preserve? Any structure going from radial to
lateral,
the
Radial
lateral
to, yes. Yes.
Come.
Lateral antebrachial cutaneous, LABC, lateral antebrachial cutaneous.
Anything else? Very commonly you come across when you dissect.
From artery, vein, and radial artery, cephalic vein.
Now, which now you will preserve?
From lateral antebrachial.
The branch of radial nerve.
Superficial branch.
Isn't it?
Yes. I thought the lateral antebrachial cutaneous.
No.
Okay, and you're right on the vein also. Vein also has to be preserved. Rather, can be preserved.
Yes.
Okay, but nerve is more important. Why are superficial? I just wanted to ask.
So that when we put the skin graft over the donor area, and the uptake will be better if there is preservation of the fascia.
Normally, what flap we take normally? Can be taken in many ways, can be modified. What you have seen taking your consultant and all that, what they are taking?
Suprafacial, sir.
Suprafacial means you are always keeping above the fascia?
Yes, sir. Only when we encounter.
Till what structure you see, you will be suprafacial.
No, she's saying we are always superficial.
No. Is it?
She's saying, isn't it, Ankita?
Yes, sir. I have seen. Yeah, I have not always, sir. When we come near the vessel, we have to go subfacial.
No.
Near the vessel.
Just the vessel only. Otherwise, you are superficial always.
Yeah, sir. Near the vessel, we go subfacial. Otherwise, we are suprafacial.
You have to present it differently. You don't come near the vessel. You come near the septum.
Yes, sir. Near the septum.
Near the septum and FCR.
Yes.
Okay. Yes.
So what is the benefit of staying superficial in addition to preserving the tendon coverage? What is the extra benefit, other benefit?
So graft uptake will be better.
Okay. Okay. Agreed. So you started from radial aspect, you remained superficial, you preserved the superficial branch of radial nerve, you reached the septum, and now you have gone subfacial because so one edge is elevated. What will you do now?
Then we incise, like go incise the deep
medial.
In hand, use radial or ulnar? You now come ulnar side and elevate it or no?
You have to ulnar.
Get the question.
Did you get the question?
You raise it from radial side. Now will
Yes,
you
sir.
incise the ulnar side or no?
Yes, ma'am.
Yes.
That's
Yes.
fine.
Go
There's
ahead.
no
Yeah.
catch.
Yes.
There's
Yes.
no catch in this.
Yes, sir.
There's no catch, है ना?
Yes, sir.
Okay.
That's why you should have the figures to explain.
Yes, sir.
चलो आई थिंक आपने बहुत ज्यादा ये किए नहीं है, मे बी अभी आपको रिवाइज करने पड़ेंगे. So what made you choose this radial artery forum flap? Aren't there any other flaps which are available?
Sir, I have done like decided on 3 flap options.
Okay.
The
So
first was free radial artery, second was free ELT, and third is supraclavicular artery flap or a local flap.
Is there any other flap which has got same characteristic features of forearm flap, thin, pliable?
In free flap, ma'am,
Yes.
MSAP,
Yes.
a medial sural artery perforator.
Yes.
I'll go a bit more basic. You see, you have excised the tumor, skin is intact. Why don't you put a graft simply? What is the problem with that? It is 4 into 4 centimeter defect. Why can't you put a graft on the undersurface of the skin?
Graft.
It might seem outrageous, but what is the exact reason you are not putting graft?
Sir, it will contract with time.
Yeah, it will
No.
We
contract.
have to put a
Contract
stable.
with one.
And anything else?
What are the other reasons?
Post-operatively, if we require
What is the
radiation or chemotherapy, then we should provide a flap coverage.
and the oral cavity, the coverage has to be watertight.
Yes, sir.
Yes.
Since you are going to do the marginal mandibulectomy, in case you are not,
Mandibulectomy
then
also.
it's a separate issue. Now you are going to do the marginal mandibulectomy, so chances are that the saliva may trickle down into the floor of mouth.
Yes.
So no two questions about it. It has to be a flap coverage. So what about this platysma flap? Isn't it a good option for 4 by 4 centimeter defects, especially in retromolar trigone areas?
Yes.
Are you aware of that?
Yes, sir, but I have never seen platysma flap.
No, that's okay. Don't be apologetic about it. So when the examiner gives you the option, give the benefit of your flap over the flap which I have said.
Okay, sir.
So what is the benefit?
Is a local flap mine or the free flap, sir?
You have to like sell your flap, no? Not agree to
Yes.
my. Yeah. So
Sir,
what is the
I have,
benefit?
sir, in my flap, I have chosen free radial artery because it is thin, pliable, and giving platysma will be in the local region only, in the same.
So that's better. Huh? You will finish the surgery in 1 hour. So what is wrong with platysma flap? You have to criticize my option. It
Sir,
is
it
not.
is in the region of the neck dissection.
Yeah, it is in the area of the neck dissection.
Yes.
It is, even if it was not, you are not doing a neck dissection, it is not a very reliable flap. The cutaneous part may not be very reliable. So yours is a sure shot flap. If it works, it will vascularity will be intact.
Any other regional flap you can use apart from the supraclavicular?
Sir, PMMC pectoralis major can be used, but in females we don't prefer PMMC.
Why?
Why?
Distortion of the breast.
We have been using previously so commonly in females, males.
Yes, sir, but there is distortion of the breast too, so that is why I did not choose the PMMC.
What are the other problems in this case to
One
plan
major,
PMMC?
yeah, major problem.
For PMMC, sir.
Yeah.
Yes.
You have done a marginal mandibulectomy. How would you make it reach the oral cavity?
Tunnel it.
Turn it
Is
from
it
where?
so easy?
Turn it from where? Lateral to the mandible, medial to the mandible.
Lateral.
Inner to the out.
So there is no communication as of now between the neck and the oral cavity. To make the flap reach, you will create a tunnel and then have fullness also. So, okay.
Okay.
So it is not good option. Okay. In case it is a segmental mandibulectomy you have done, then you can do. Otherwise, there won't be any space. So tight space will lead to vascular compromise.
Okay.
Alternatively, what could be the role of this particular patient about this islanded forehead flap for retromolar trigone area? Is it a good option? We don't expect you to answer, but we want you to go through all these options.
Okay, sir. I'm not sure about the.
That's fine. So these are the options which are available. One is platysma, one is islanded forehead flap, which are the local flaps. One you yourself said supraclavicular artery flaps. So all these are a bit troublesome. Anything from the neck is a bit troublesome because you're doing neck dissection.
Yes.
But islanded forehead flap could be one option. But this will lead to other problems like there will be cosmetic deformity will be there on the forehead. Okay.
Yes.
And in case you take it on the temporal branch, then it will be a hairy skin. So that is also not an option. So more or less, we agree to your plan. Free radial artery forearm flap is fine.
Okay, sir.
How will you approach the patient? Now you are starting the surgery. How will you start the surgery? Patient is on table. He is anesthetized. Now, what will you first tell the patient? Anesthetist, you are anesthetist. What do you want?
Sir,
What about the intubation and all that? Anything
sir,
special?
yes, sir. I would prefer to have a nasal intubation.
Yes.
If fiber optic is available, via fiber optic would be better under
Why
visualization.
there is a need for fiber optic?
I mean, if under guidance it can be, under visualization it will be.
Ankita, one thing I will
There's
advise
a
you,
mouth opening is
always
good.
go whatever you are doing in our institute. Normally, freely what we are doing. There may be indication, there may be
Oh.
indication of using fiber optic. But broadly, we are all doing right things. Remember this thing. You should not go by high-fi techniques and all that. Whatever you are
That
doing,
too,
in
there
your
is no
unit, that is good.
trismus,
That is
no
good.
trismus, and there is
There
nothing.
may be, yeah, madam is rightly saying there must be indications for that also. But seeing this patient, whatever you will do, that is the fine thing. And nobody will question that.
Whatever you say, there's you have to substantiate. Okay.
And please, your exam going now. Remember one thing what Dr. Parashar was also telling you, that you have to be within the question. Don't go beyond the query what you are being asked.
Okay.
Let the examiner put the second. What you are answering in single question, two questions, maybe examiner's second question is that.
Okay.
You tell
So
the
you are
nasal.
losing a chance of the second question, right?
Yes, sir. Yes, sir.
If you are telling me nasal intubation, it was enough.
Okay.
Now
Sir.
my second question was you didn't let me ask if patient has trismus.
Okay.
Yes.
That was my second question, but you didn't give me the chance.
Okay, sir.
You got my point. So you have
Yes.
to be within the you have to speak what you are asked.
Yes.
Now you have anesthetized in nasal intubation. Now how will you mark? What will you incise? How will you make your incisions?
Sir, after the patient has been nasal put under anesthesia, sir, we would like to go for neck dissection first and then excision of the of the of the malignancy, since I don't want to do seeding of the tumor into the neck. So I
Again,
would first go for.
don't.
No, nobody asked you.
Okay, sir. Okay.
I didn't ask for seedling, and
Oh.
you have not. Matlab na, I can say very bluntly, you have not to teach. You have to just reply the questions, right?
Okay, sir. Okay, sir.
You
Right.
may, that may,
I asked you what will be your incisions. How will you do?
so you
Okay, sir.
tell the what is the neck incision you give, how you
Yes, sir.
do, and then go for the wound excision. The examiner may ask you why not you can go in a reverse way. Then you can answer. Okay.
But she didn't
Okay.
let us ask
So
why first neck and why not the oral cavity.
why not oral cavity?
Good
Okay.
luck because she's going nicely.
Sir, I would first like to go for marking of a lip split incision and a modified McPhee for the neck. Only the upper incision of the modified of the McPhee's incision with a lip split incision for exposure of the oral cavity.
Then you will do the neck
Uh,
dissection.
yes, sir. Then I would go for the neck dissection first.
Then
After that, I would like to go for excision of the malignancy.
what incision you will go for this oral
Sir,
cavity?
for oral cavity, I would like to do a lip split incision and a 1
You will
centimeter
mark somewhere this lip split. How will you mark?
sir, in the middle of the lip and curve towards the chin. In the chin region, I would like to make a C curve
Why?
and one, yes, sir, to break the straight line, sir.
Hmm.
And the inferior border would be 1 to 1.5 centimeter below the border of the mandible, sir.
You have to actually incise from outside, and what about the inside oral
Inside,
cavity?
sir, 1 centimeter margin I would take all around the malignancy,
That
sir.
is good. If we go to lip, now you are splitting the lip.
Yes, sir.
And how will you
Then,
proceed
What
inside?
about the
Neutral curve.
yes, sir. Okay, okay. So, yes, sir. After splitting the lip, I would like to, for the mucosa, I would like to keep, like go from anterior to posterior and leave a little bit of mucosa towards the cheek side so that to have purchase.
So in your hospital, are you excising or somebody else is excising?
Sir, ENT department is excising the.
Excising.
Head and neck surgeons.
So what will you tell them? So we'll not discuss that. So you have told them that you can go ahead and do a lip slit incision. You are happy with that, and
Yes,
use a McPhee incision for neck dissection. Incision
yes,
planning is plastic surgeon's part. That's fine. So
yes.
what else will you tell them?
Sir, while excision, I would like to tell them regarding if they could save the facial artery on the ipsilateral side and to leave a little bit of mucosa on the more towards the buccal side so that I have purchase for inset of the flap.
Why facial artery you want to save?
Sir, for anastomosis of
Okay, so
the,
you are doing anastomosis with facial artery,
yes, sir, ipsilateral.
ipsilateral facial artery. That's fine. And vein?
Sir, the venicometance, facial artery and facial vein with the venicometance of the radial artery.
Then why have you preserved the cephalic vein?
Sir, actually, the advantages of if we do sir, the venicometance is the I mean to say it is the valveless system, and if there is for salvage option, we keep one artery and two vein anastomosis.
So would you anastomose your cephalic vein then?
Yes, sir, I would anastomose.
It too?
With what?
Sir, one I would anastomose with the facial vein, and if
what is the other vein you will anastomose?
वही आपने बोलना था ना उनको प्रिजर्व करने के लिए.
yes,
You must be having tumor colleagues there na, for the discussion pre-operatively with your colleagues.
Yes, sir.
Are you having regularly those humor clinics with them? Planning,
What
preoperative
are the other
planning.
veins in the neck?
Facial and jugular. Jugular we have.
Internal jugular.
No,
Jugular.
external, sir.
External jugular. Okay. Okay.
Yes.
External jugular and anterior. Okay, you can do that.
Or any branch of the external jugular.
Internal.
Good, good.
Yeah, okay, it's okay.
Do you know of any modifications of radial forearm flap you are taking? What are the various ways in which you can harvest, you can use actually, utilize this flap? You can take it as a free flap, right?
Yes, sir.
Faciocutaneous. Then what are
Yes,
the
sir.
other modification you can use it as, utilize this flap?
Sir, osteocutaneous also we can take it.
Very good. And excellent.
Uh, Sir, I know we can make it sensate by taking the lateral antebrachial cutaneous
Yes. Further.
nerve. Um, Sir, I only know of these options.
Pedicle you cannot take?
Yes, sir. But in oral cavity, how?
No, I am talking general.
Okay, okay.
This
Yes,
is
sir.
not for
Tell
this
me in
case.
general.
Okay, okay. Okay, sir. Yes, sir.
Apart from this case, what else it can be utilized as what?
Yes, sir. In hand defects, we use for radial artery or reverse radial artery, both options.
Yes, then very good.
As a pedicle flap.
Huh? What?
As a pedicle flap. As a pedicle
Yeah.
flap, sir. In reverse radial, we take for dorsum of the hand defects. Sir.
Done. Now pedicle and anything else.
Sir, osteocutaneous. But sir, I don't need these many options.
What is a flow through flap?
Sir, I don't know.
So you should read about it, the flow through flap, and also.
Have you heard of radial flap as a facial flap? A radial artery based facial flap taken from the forearm.
No, sir.
Okay. Can it be utilized on the face in any way? Radial forearm apart from the free flap. What are the ways so that it reaches the face?
As sorry, waltzing
It's called waltzing.
for face.
How can it reach the face without microvascular anastomosis? How can it reach?
Sir, that pre-lamination and prefabrication.
That are the modifications. Again, you didn't tell now. That very good. How can it reach? I have to make a nose or like that from the
There's
foot.
a specific name for
But
that.
I have no expertise. I don't know how to anastomose, nor I have microscope, no expertise, right? Micro instruments and all that in a rural area. But I have to make the nose from the radial forearm. How can I make the radial forearm reach my nose, reach my face? What is corporeal?
Have you
What is
seen the photos of Tagliacozzi flap and all?
No, ma'am.
No?
No, ma'am.
just open
So
the
what
book
is-
and please.
You read about extracorporeal radial arterial forearm.
Extracorporeal. Okay.
Very important, very frequently asked.
Okay. So especially useful in cases in which the recipient vessels are not there. They could be post-artery cases or something else. Okay. Read about extracorporeal radial artery forearm flap and read about reverse flow radial artery forearm flap. Fine.
Can you take anything else with the forearm flap, especially for the oral cavity? Not in this case, anywhere else. With the
Palmaris sling, we can.
some other structure.
Yes, palmaris longus for the sling.
For what?
Oral competence sling. PL,
Oral.
palmaris longus sling.
Oral competence. Any other you know of? You were telling about the prefabrication. What is that?
So prefabrication and pre-lamination, these are two techniques which are used to add additional tissue.
Again, I have to stop you. You
Yeah,
were
yeah.
asking what is prefabrication. We didn't ask you about pre-lamination.
What is prefabrication? Just exemplify. If you don't know the definition, just example how you can prefabricate.
Sir, in this case or
No, it is
No,
general, beta.
in general, Ankita, you leave the case.
Actually, whenever you talk of radial forearm flap, it is a so lengthy and so much of discussion is done. Then we used to forget about the case, right?
Okay.
Radial forearm is a very vital flap.
Okay, sir. Sir, when we add new blood supply to the flap, it is prefabrication. And then we transfer the tissue.
Example? I could not understand. You add a vascular, I have a radial forearm flap. Why will I need to supply more blood supply to it? Are you saying like that? I want to supply it more. My radial artery is not enough for this flap? Or I'm twisting it another way?
Yes, sir.
I'm twisting it. Read this prefabrication, pre-lamination.
Rhinoplast, I think.
Yes.
I'm not sure.
चलो ठीक है डॉक्टर अंकिता, आपका presentation was fine and the flap choice also was fine, but only thing is ALT could also be a good option, except for in case the limb was not bulky, because it is a small defect and there won't be any donor side mobility at all. You can do the primary closure.
Okay, sir.
But in case you have examined the patient, then it is okay. So examiner will usually ask you what is your recipient vessel, what is the recipient artery, recipient vein, and why do you take an extra vein, and where do you anastomose it?
Okay.
Fine.
Okay, sir.
Then there were minor things which you already pointed out.
Yes, sir.
Dr. Lakshmi, anything else we need to add to this discussion, or it's fine?
Yeah, actually it went on well. All points were touched, and Ankita presented well and answered also well. Only one thing, Ankita, your plan, you have to put the diagrams and operative steps also. You should be in position to tell. Okay.
Okay, ma'am.
Well done. And we'll end the session, shall we?
Yes,
Yeah.
I thank all of you, Dr. Atul, for wonderful lecture and followed by the very good discussion, which is useful for PGs, and Dr. Umar for good participation. I